thank you everyone for the commentary, and I've now slipped back into co-chair mode to introduce my co-chair, Anneke de Haan from Groningen, who actually started off as a human movement specialist, but is now transformed into a gun clinical trial project manager for a wide range of conditions, including Dupuytren's and Lederhouse. So the floor is yours, Anneke.
Thank you, Jared. We just heard about some background and research which is ongoing, and I will now dive into the clinical practice of radiotherapy. So how do we prepare the treatment, how do we deliver the treatment, and how will we follow up our patients? I have no personal disclosures, and these are our departmental disclosures. I have to mention that everything I tell is based on how we deliver the radiotherapy in the DEPART trial, because in the Netherlands, radiotherapy for Dupuytren's disease is currently not available, so it's all within research. And in the DEPART trial, we give radiotherapy for early stage Dupuytren and post-operative after the PNF. And I would like to mention that especially when we deliver radiotherapy after the PNF, when we have the intake at the radiotherapy department, this around 6 to 10 weeks after the surgery, the hands are recovered very well. So there are no wounds left, and the hands are ready for the radiotherapy treatment. And you can see that on the pictures where the treatment area is delineated. So that's very important to know. During the intake with the radiation oncologist, the patient gets a lot of information about the treatment and also about possible toxicities. And at the same time, the radiation oncologist delineates the affected area. For the early stage patients, those are the visible and palpable nodules and cords. And for the patients who had the PNF, it's the surgical treated area. And after the intake, at the same day, we move on with the preparation procedures. The first step in the preparation for treatment is that a custom hand cushion is created. This is a special cushion with little balls inside. It's in a sealed bag, and when it's opened, a chemical response starts, because when air and water is applied, the balls will harden, and the hand is put in the cushion. And the cushion is essential for our treatment because it ensures that we have a precise precision during the radiotherapy. Once the cushion is prepared, we delineate the radiation field. In our center, we do not treat the whole palm, but we delineate with a margin of 1.5 centimeter. So the radiation oncologist already delineated the affected area, and then we prepare the margin. Dots are put around, and then the dots are connected with a line. So then we have our treatment area, and then the treatment area is duplicated on a transparent sheet so that we can always use that again when the patient is in the treating room. And a lead sealing mold is fabricated in the meantime. Then we have prepared and we are ready for treatment delivery. And the treatment we give is a total dose of 30 gray, and we do that in 10 fractions. After 5 fractions, there is a treatment break of 4 to 12 weeks, and then we move on with the next 5 fractions. The target is the fascia, and there are several treatment techniques we can use, and which treatment technique is used is based on the preference and the availability in the institutes. In our center, we treat with the electrons. So the next slides will be based on the treatment with electrons. Here the patient is in the treating room, so we are at start of treatment delivery, and you see the cushion again. And the radiation field is projected on the hand with the use of the lead mold, which is in the head of the treatment. So the green light is projected on the hand, so we are sure that we have the right area covered. Once we have the treatment area correctly applied, a bolus material is put on the hand, and this bolus material makes sure that the radiation dose is closer to the skin surface. The position of the patient should be comfortable. So the patient sits or stands next to the treatment machine and with the palm of the hand under the treating beam. The whole treatment delivery time of one fraction is only 1 to 2 minutes, and the patient will not feel anything from it. It's simple. So then the treatment is delivered after 10 fractions, and we move on to the follow-up. The first follow-up is immediately after the 10th fraction, where we have a little talk with the patient about any acute toxicities. Then 1 month after the end of radiotherapy, we contact the patient by phone again to ask for toxicities. And then we move on to the physical follow-ups. The first year, we see the patient every 6 months, and then yearly until 5 years, and then again after 7 and 9 years, and then the whole follow-up is completed. During the follow-up, we perform hand measurements, quality of life and functionality is questioned with questionnaires, and we also score the toxicities. Something about toxicities after radiotherapy. This is also based on what we saw in the clinical practice. Here a hand which showed dermatitis, radiation, and dry desquamation. In the first picture on the left, we are 9 days after radiotherapy, and the patient reported redness of the skin, burning sensations, and some dryness. 20 days after radiotherapy, there was a dry desquamation. And when I saw the patient 6 months after radiotherapy, the hand was recovered and there were no toxicities left. And the only long-term toxicity I've seen so far in the trial is a mild skin dryness, and some examples are given on the pictures. And patients report that this dryness does not negatively impact their daily life. Some take-home messages. As Jared already mentioned, radiotherapy is a non-invasive treatment. It's easy to apply, and based on the clinical experience so far, the toxicities are only mild and limited, and it's well tolerated by the patients. But scientific research is needed to establish efficacy and safety, so we are really looking forward to the results from our trial. A special thanks to all the people in our hospital for our collaboration, and of course also to the Genesis Care team. So thank you.
So maybe we'll open up for questions. Great talk, Anneke, and we've got maybe Gary first and then further up the front afterwards.
I'll speak loud also in case the mic stops like you did to Charlie. Thank you, Anneke. Great presentation. 2 questions I have. In the case you showed of the middle ray being affected, I wonder why you would not include the ulnar side of the hand. I know you said 1.5 centimeter margins, but why not include the rest of the hand with the likelihood of ulnar disease developing in the future? Second question, the timing after PNF, is it necessary to wait 6 to 10 weeks if there's no skin tear, or can you do it earlier? Thank you.
Okay, with regard to the first question, in our institution, in our opinion, we should stick to the affected area which is there at the moment of treatment, so that you should avoid treating healthy tissue, to avoid any, if there are any, to avoid problems. I know that in other institutions the whole hand palm is treated, but we are convinced that you should stick to the affected area, also based on the ALARA principle, and that you only treat as low as possible. And with regard to the second question, sorry, what?
Second question was, why did you wait 6 to 10 weeks after PNF, especially if there's no skin tear? If you do it earlier, it's more of an inflammatory phase.
Yeah, first it was in the study protocol that we should start within 4 days from the procedure, but I think logistically that was a challenge. Jared, maybe you can...
So you can start earlier. It's not banned. I think there was a surgeon here as well.
Hopefully it'll work better this time. So 2 questions of this nature. Patients contact me who have had the split protocol. They'll have half their dose, and then they're waiting for their second dose. And the question that is posed to me is, I've had this, I'm doing well, I'm not sure I want to have the second round of radiation. I've had 15 gray, and is there a problem if I don't have it now? Is there a problem with the effectiveness if I delay my second round of treatment? My answer to them is, well, if you delay it until you start developing a contracture, you've burned a bridge. So it is, let's say somebody just wants to hold off till later on in the year, does that change the efficacy? And the second is, I've had people contact me saying, I had radiation, everything was fine, it's been 3 months, and now I've got some inflammation in my hand, and I worry, is this a bad sign? And after each of these questions, my first answer is, I'm not a radiotherapist, you need to speak with someone who knows what they're doing, but is a delayed phase of inflammation, is that a thing? And so those are my questions. Is delay a problem? And what should I tell people who say, gosh, my hand's inflamed now, I'm concerned?
Yeah, the dose of 30 gray was chosen as that is the dose known from previous literature that it's, but actually, I think we don't know. But as this is within research, we should stick to the protocol. But I agree with you that it might be interesting that if we find effectiveness from radiotherapy with 30 gray, that a next step could be to investigate if a lower dose of 15 gray might be worthwhile. But for now, I think we should stick to the 30 gray with the treatment break and complete that treatment. With regard to the inflammation 3 months after treatment, we do see it, and I think the hand needs time to recover and that it's no issue. In general, at 6 months after treatment, we do not see such side effects anymore. So it is possible, and I don't think patients should worry about. Great. Thank you. Yeah.
Well, we just got one here, and then quick one from Heinrich, and then we're going to have to wrap up.
Thanks to both of you for great talks on the role of RT. And as a hand surgeon, I have a certain perspective on treatment of Dupuytren's, but it really requires a multidisciplinary approach. So thanks so much for teaching us. It would be wonderful if we have really great data that RT can decrease the recurrence of Dupuytren's after needle aponeurotomy or any treatments. When is the 9-year data? When are we going to have this answer?
Well, I might take that one. I guess, as I sort of pointed out, we're still accruing for the needle aponeurotomy arm, so it's going to be a slow burn, unfortunately. We just got to, first thing we got to do is accrue the patients to power the study enough to actually be able to detect a difference. So if you've got some radiation oncology colleagues nearby, let's talk.
Science goes on with patients being irradiated, and I have irradiated through my 35 years at least 4,500 patients, several from Netherlands. And the funny thing was, during COVID, they had received radiotherapy, one series. They couldn't come back. So COVID was an excellent phase to learn what happens with a second series. So patients from USA, from Netherlands, other countries, they came as earliest at 6 months, and they showed they had progression. I wrote a letter to the custom officers, and they could pass the border and get the second series. 3 years, 4 years later, after COVID, patients came back being treated with one series and were still improved. So your question is well answered. We should not give always a second dose. And the second dose at 4 or 6 weeks is wrong, because you need 4 weeks to have the skin repair. You need 2 other cycles of about 4 weeks turnover skin, that the skin shows that it can repair completely new. And at 3 months earliest, you would give your second series, asking what was the toxicity of the first series. And you might reduce your dose if you had toxicity in the first series. Yeah? Giving less dose, giving less fraction. So you can learn a lot. And interesting, if you have similar disease in both hands, you treat the severe one. And you observe in about 20 to 30% that the other hand has also improved. So there is a systemic factor, let's say influence on TGF-beta, on genes, which also is acting in the other hand. So you can delay treatment in the single hand when you have an effect. And my young Lederhost patient was 9 years when he was treated. He came back after 25 years. We treated at 9 years a Lederhost disease with a size of 6 by 5 centimeters. Only one series. 20 years later, he has not a growth delay. He had a tiny nodule 2 by 1 centimeter. And so for him, 15 gray was sufficient. And that's our lessons we still have to learn. We have late responders. We have acute, even young patients. They may require radiation much earlier than you would think because you are afraid of possible cancer. We have never, ever have in the literature any cancer case so far. The one which was published was 2 hands, both irradiated for hyperhidrosis, 16.5 gray. Why was the one hand, the right hand, cancer and the one non-cancer? It was shown as a danger for radiation, but you could also approve for not getting cancer, because the right hand had probably exposed to other sites. And if somebody develops a redness in your hand 3 months later, you should ask what he has done with the hand.
Okay, good thought. We might wrap it up now, just since we're right on schedule. So please join me in thanking Anneke.